මම කොහොමද විනාඩි 40 Okay, see my screen?
Yes, sir.
Okay, good. Right. So today we are going to discuss about RH Iso immunization. Let me put it into full screen. Okay. Right. Okay. So RH Iso immunization is what happens when a baby who is RH positive, because the father is RH positive, becomes is in a tummy of a RH negative woman. Then what happens is, if you are RH negative, you will not have RH antibodies developed in your body. So once you are exposed to RH positive blood, then what happens is your body will start producing RH, the antibodies towards RH positive blood. And these antibodies are basically IgG type, which process the placenta and can affect the subsequent pregnancies. So the basic gist of the lecture is this, but we will go into detail how this happens and what we are going to do about it. So in 1939, Levin and Stinson discovered the problem of red cell agglutination, right? So red cell agglutination was the issue. When red cells agglutinate, they are destroyed by the reticuloendothelial system, and that will cause this you call it the kernicterus or jaundice in the neonate, that happens due to destruction of red blood cells and release of bilirubin system. So this was first discovered by a person called Levin and Stinson. And then in 1940, the Landstein and Wiener. Now, Wiener is a very famous hematologist. So Landstein and Wiener, using RH monkeys or rhesus monkeys, discovered this RH antigen. So they found out, these are the two people who found out that RH antigen is the cause for the problem that they are having. Then in 1953, this Bruce Crown showed that this RH immunization was the passage of fetal RH positive cells from the baby to the mother. So RH sensitization can occur at any point. Basically, it happens at the time of delivery, but it can happen alternately even if the baby's blood, RH positive blood gets mixed up with the RH negative blood of the mother. And the Coombs test was developed to detect this problem, the Coombs agglutination test. So what are these rhesus antigens? So the nomenclature of RH system was devised by two people called Fisher and Rhesus. Actually, they both invented it at the same point. So they combined the names and ultimately gave Fisher and okay, hold on. The D is the major cause of RH incompatibility. So E and C also can cause some sort of hemolytic disease of the newborn, but the D is the major culprit. That's why we say D is the major incompatibility cause. So it is
Hello, sir. Yes, sir.
15 to 17% of white cells so nearly 20% of them are having this Rh negative problem, right? So the anti-sympathy and the D antigen has never been sorry, I got a we got a cut in our connection again because of this rain. I think we are okay now again.
Yes, sir.
Okay. Give me 1 minute. I'll share my screen again. Yeah. Yeah. So so there are 3 pairs that we stopped at that point, and the antigen, the capital D is not isolated, but we for completeness sake we include that in our nomenclature. Right? Okay. The problem with D antigen is it is 50 times more immunogenic than the Rh other antigens, and because of that, when it is mixed with the negative blood, it develops a rapid reaction of antigen and antibody production. The sensitization risk is there towards every trimester, but it is maximum at either third trimester, as you as you can expect, because the baby's blood volume is increased at that point. So if the blood volume is less, the chances that you can get sensitized is less. So when you get exposed, first there will be initially a primary response, that is IgM response, we all know, and that's a weak response. But the problem is the secondary response. If the blood gets exposed again for a positive blood group, then of course it's a very rapidly developing IgG response, and these IgG are very much smaller than the pentamer IgM, and they can cross the placenta and damage the fetus, right? So IgM response is the primary response, IgG is the secondary. Once a woman is sensitized with Rh negative, Rh positive blood, and a negative woman will be sensitized for the rest of her life. So anytime she is re-exposed to the same type of positive blood, she will get rapid production of antibodies in her system. It will never be forgotten. So we can't say we had a mistake, next time it will not happen. You can't say once it is exposed, it is exposed, and it is going to be there for the rest of the life. So what happens in pregnancy? When if she's a sensitized woman, she gets pregnant again, and that will, if that results in a fetal-maternal bleed and mixing of Rh positive blood with Rh negative blood, there's a rapid response, and this rapid response will develop Rh antibodies which are of IgG type, and these Rh antibodies will cross the placenta. They will cross the placenta and they will go and damage the, they will cross the placenta and they will go to the baby's system. And in the baby's system, its antibodies will result in agglutination of baby's blood, and this baby's blood, which is aggregated, will be destroyed in the reticular endothelial system of the fetus. When the red cells are destructed, then the baby will develop one thing, they will have jaundice, but in the mother's tummy, it won't come out. Why? Because the mother's liver is capable enough to wash out any excess jaundice or any excess bilirubin that is developed in the fetal system. Only thing that the baby can have intrauterine is anemia. Anemia is the problem. But what happens after that? What happens is when the baby is delivered, if somehow we manage to deliver the baby, then the baby's liver now has to clear up all the bilirubin that is developed in the baby's system. Now the baby's liver is immature, and that will result in hemolytic disease of the newborn, right? And the newborn will cause severe jaundice and brain damage and fits and all these problems, right? So what are the features of intrauterine anemia? Because, I mean, our part is neonatology part is jaundice in the baby, and that will be discussed in neonatology lectures. But as obstetricians, we have to manage this baby until the baby is delivered, and then we have to, what happens inside the tummy is anemia. I mean, so we have to know methods to detect anemia. So the features of anemia are polyhydramnios, that is increased amount of glyco volume around the baby. Then enlarged fetal heart, that is heart failure. There will be hyperdynamic fetal circulation, and the middle cerebral artery Doppler will show increased flow. With that, the baby will be hypoxic and the baby will be lethargic because of the anemia, and there will be reduced fetal movements. And when you do a CTG, it might be showing severe anemic symptoms like sinusoidal pattern and reduced variability. So these are the indicators that the baby is suffering with fetal anemia, right? Can we prevent it? Well, we can definitely prevent it nowadays, because once, if there is an event of sensitization, if we can give anti-D antibodies, so these anti-D antibodies will attach to the Rh positive fetal blood and destroy it. So if we can give anti-D antibodies within 72 hours of giving birth to the mother, and that anti-D antibodies will go and bind to whatever the mixed fetal blood cells and destroy these fetal blood cells. So if we can somehow destroy these fetal blood cells before they go and sensitize the woman, then we can avert the problems that can happen in future pregnancies. Normally, in Sri Lanka, so normally, once we give the anti-D dose, anti-D normally we give 500 international units. So once you give this dose, it will go and bind to this thing and the fetal blood cells, and they will destroy. Normally, 500 international units is enough to normally neutralize about 20 how much 500 is enough to neutralize about 100 5 ml of 5 ml of fetal cells. But in Sri Lanka, we have 1500 vials, international unit vials. We don't have the 500 ones. The current recommendation is only to give 500 international units. But in Sri Lanka, we don't have the 500 one. We have the 1500 vials. So 1500 international units is equivalent to 300 microliters, and that is a huge amount. So when we give this amount, normally this is adequate to neutralize about 30 ml of Rh positive blood. 30. So 500 is for 10 and not 5, it's 10. But 30 ml needed amount we are giving, because we don't have the low dose vials. But because of that, we are giving overdose. So because we are giving overdose, the chances that this sensitization occurs in our women is very, very rare, right? So normally, once the baby is delivered, within 72 hours, we give 1,500 international units of RH antibodies to the mother. So this called the
Hello, sir. Excuse me, sir.
what happened.
Excuse me, sir. We can't hear you, sir.
That is okay. So the routine antenatal RH prophylaxis, so far it's not practiced in Sri Lanka, but I believe it should be practiced, and we should routinely offer about 1,500 units of vial of anti-D ROGAM. So either you can give 2 doses, but the problem is if we have 1,500 units vials, you have to make 2 vials at 28 and 34 and throw away 1,000 each, because you had to use it on the same day. So because of that, what we do is we give a single dose of 1,500 at 28 to 30 weeks. That's the most suitable one that we can do, but still it is not given in the government sector. Okay.
Excuse me, sir.
Yeah.
Sir, we couldn't hear you during the last slide.
Yeah, this slide is it?
Yes, sir.
Okay, I'll go back to this. Now, we have 2 types of prophylaxis. One thing is postnatal prophylaxis, that is given within 72 hours of childbirth. Other one is the antenatal prophylaxis, that is given before childbirth. Now, antenatal prophylaxis is not essential because the chances of mixing fetal and maternal blood is very less in the antenatal period. But still, for very much safe, I mean, if you have to be very much safe, we can give antenatal prophylaxis as well. There are 2 methods of administering antenatal prophylaxis, that is giving one dose of 1,500 units at 28 to 30 weeks. Now, other method is giving 2 having 5,500 units vials. So if we are having only 1,500, if we are having only 1,500 units vials, then we are at a problem, because once you break a vial, you have to give all and finish it. So what we normally practice in private sector even is we give 1 vial of 1,500 at 28 to 30 weeks. Other method is giving after delivery. After delivery, we give 1 vial, that is 1,500 international units. We give a single dose, that is within 72 hours of childbirth. Right now, that is actually overdose. Current recommendation is to give 500 and then check whether there is any more blood that is needed. We do a test called Kleehauer test to diagnose that. But in Sri Lanka, we don't do Kleehauer because we give 3 times the required amount that is needed to give. We give overdosing because we don't have the 500 international units vials are not available in our country. That's why, right? So that's what I told. But I mean, it is a universal precaution that we do, that we give this injection, but still we find it. Why is that? Well, circumstances can occur at not only at the birth of the baby. If you have therapeutic or spontaneous abortions, ectopic pregnancies, threatened miscarriages, any clinical procedure like Coriolis villus sampling, amniocentesis, photosynthesis, and so on, or any clinical procedures like external cephalic versions, all these things can cause what you call sensitization. So sometimes we might not be covering all these events during our antenatal period. So that's why we still find sensitization events in our country or in the world, right? So it might be due to failure of routine antenatal prophylaxis. It might be not identifying a clinical event actually as a clinical event, or it might be that we are giving the postnatal this thing late, or it might be due to spontaneous immunization in spite of recommended regime. So ideally, we have to achieve 100% coverage of this system so that we will not have this problem in the future. So we have to give antenatal prophylaxis as a routine and a very uniform basis. And if we cover this routine and uniformly the antenatal and postnatal prophylaxis, then we can be pretty sure that this problem will be eradicated from our system. But still, you have to be pretty sure that the coverage is 100%, which is still not there. So, what is this RH system? So, RH system commonly is associated with severe hemolytic disease, right? So, out of all the antibodies, D is the most commonly associated severe hemolytic disease, right? And if it occurs, if only the mother is RH negative and the fetus is RH positive, and both anti-C and anti also can be associated with hemolytic disease, but they are less common than the RH anti-D RH negative sensitization events. That is because as I told you, the immunogenicity of the other ones, the other anti-E and anti-C are very much less than the anti-D anti-D RH antibodies, right? In addition to this RH rhesus antigens, there are so many other antigens that can develop in our body. The antibodies that can develop in our body. These are, if you tell in, if you can remember, they are like Kel, Duffy, little E, S. So these antigens also are responsible for developing an antibody immune reaction in our body, but they are very rare. So the commonest type that we come across is the rhesus one, right? That is the commonest type. Then there's another type of hemolytic disease that is called the ABO hemolytic disease, right? Now, we all know our blood group is divided by the ABO system. Now, after developing ABO system only, we found out that there was this RH negative and RH positive due to this rhesus antibodies, and that also is immunogenic. But then after some time, they realized that not only this RH system cause antigen reaction, but ABO system also can result in antibody production, right? So this is also common in the sense it can occur up to 2 to 3% of cases, but it will rarely cause a severe hemolytic disease of the newborn, right? But the problem is with unlike in RH system where maternal and fetal blood mixing is essential for sensitization, the ABO system does not need a mixing of maternal and fetal blood. Why is that? That is because these A and B substances are found in lot of this environmental stuff like bacteria and food types. There's A and B antigen substance are there, and they can develop antibody reaction in our body. So we might have antibodies even if we have not exposed to the opposite blood groups. This because of this problem, this is quite common. But the problem is severe hemolytic disease is quite rare in this, right? This is commonly seen when the mother is O and the father is A or B. So if the father is A or B, the baby can be A or B, and the mother is O, then you can see a ABO hemolytic disease of newborn. Actually, this can be somewhat distressing, and it can cause some sort of hemolytic disease of newborn, but it is not severe, right? So what are the tests used in the management of alloimmunization? Now, once alloimmunization is actually the mixing of human blood with human blood and causing immunization reaction. Now, we have to, once we think that the mother's blood, once we find out that the mother's blood group is negative and the mother has developed antibodies, it is important to do paternal blood group, right? Now, if there are, now when the mother is Rh negative, then we have two possibilities. If the mother is Rh negative, the baby can be either Rh negative or the baby can be Rh positive. If the baby is Rh, if the baby is the father is Rh positive, then father has two possibilities. Father can be either capital D, simple D, or father can be either capital D, capital D. If the father is capital D, the baby has 100% chance of becoming Rh positive. But if the father is capital D, simple D, then the baby has 50% chance of Rh positive. So what we do when the mother is negative is we are going to check whether the father is positive or negative. If the father is positive, then we know at least we have 50% chance that the baby is positive, right? At least 50% chance that the baby is positive. Now, when that is the case, we can do a thing called prenatal diagnosis of fetal RHD status. Give me 1 minute. Give me 1 minute. Okay, sorry. So when it is father is positive, we have to check whether the baby is now positive as well. So if the baby is positive, then of course there is a chance, and if we know that the mother is sensitized, now we have to see whether the baby has a chance of becoming hemolytic, getting hemolytic disease of the newborn. For that, we have to first see the baby is positive or not. For that, what we do is we do this test called NIFTY. NIFTY is non-invasive perinatal testing. Now, when we do NIFTY, we get some blood from the mother and we squeeze out the baby cells out of that. Baby cells normally will be detected in mother's blood. And from that, we do a PCR and we check that baby's blood's RHD status. And if it is Rh positive, now we know now two things. One thing, we know the mother is now sensitized. That, of course, we knew from the beginning. Now, once the mother is sensitized and the babies are Rh positive, we know another thing now. Second point is we know that these antibodies can cross the placenta and now can be damaging the baby. So now we have to see how bad is the damage. How bad is the damage? Do we have to deliver? Can we keep? For that, we have to do special tests. Now, the others, the other slide, this should come later, but we have to go to the slide where we stopped. Give me 1 minute. Okay. Now then, now when we know that there can be sensitized events, we have to see whether the mother is having unexpected antibodies that can go and damage the baby, and what sort of a damage is there. So for that, we do a test. When we see a mother with Rh negative blood, what we do is we do a test called unexpected antibody test, right? So when we do this unexpected antibody test, then we will know whether there are unexpected antibodies or antibodies that can cross the placenta and damage this Rh positive baby. Now we know that the baby is Rh positive, so the baby can be damaged if this antibodies comes. So we have to see how much of antibodies this mother has. So for that, we do a test called unexpected antibody titer. Now this titer normally is given in by convention. It is given 1 in 16, 1 in 32, 1 in 64, like that. Now the higher the underneath value, that is 16, 32 and 64, higher that value, higher the titer. And in that sense, the damage is more if we get 1 in 64 than 1 in 16. So then we have to realize about the critical titer. The critical titer. The critical titer is a titer when we check from the hematology lab. When we check, the critical titer is a titer that can that has antibodies that will cross the placenta and damage the baby. And once it goes beyond the critical titer, then the baby can develop anemia. Now, critical titer will be given by the lab. The lab will do this test and tell us, okay, the mother has developed antibodies and the mother's antibody levels are at a critical level. Now, when it is in a critical level, then we know the baby can be damaged. Now, how much is the damage is our next. Now, once we know that mother is sensitized, then we know the baby is positive. Third, we know that the mother has now antibodies which are at a critical level as well. Now, the fourth thing that we have to know is the baby now getting affected because of the critical level it has reached? For that, we have to see whether the baby is having anemia or not. So how are we going to check whether there is anemia or not? First thing that we can do is a thing called amniotic fluid spectrometry. For that, we have to do a thing called amniocentesis, and we take some amniotic fluid and we check the bilirubin level in a optical density of 450. In that optical density, the bilirubin level is checked. And we have a graph which has 3 zones: zone 1, zone 2, and zone 3. If the baby's 450 optical density bilirubin level is in zone 1, we call it, it's only mild hemolytic disease. Zone 2 is moderate. Zone 3 is severe. Now, according to these zones, we have to treat. Now, if it is in the mild zone, we are okay. If it has gone to moderate zone, we'll be careful, but we have to know that the crossing is now happening and the baby is getting little by little anemic. The more the baby is anemic, the bilirubin level increases because bilirubin is developed by destruction of red blood cells. If it goes to severe HD, then we have to act on that. What is the action? I will tell you at the end. The other one that we can do is the middle cerebral artery Dopplers. Now, middle cerebral artery Doppler is also a method that you can check the fetal anemia. It says it's not a direct method, but it's a non-invasive method. Why I'm telling it's non-invasive, we are not going to prick the baby or prick the mother. What we are going to do is we are going to do ultrasound scan and check the blood flow in the middle cerebral artery of the baby. In the middle cerebral artery, if the baby is having anemia, the blood flow increases. And when the blood flow increases, then we can get the amount of increase. So the more the increase, the more the chance that the baby is having anemia. That's what the argument. So we have to see how bad the increase is. So what we do is we check the peak systolic velocity of the systolic blood flow in the middle cerebral artery, and we check the 1.5 multiples of median value. This is one. If the peak systolic velocity is more than 1.5 multiples of median කියලා කියන්නේ it is a statistical jargon actually. So we check at 1.5 multiples of the median value. If that value is more than if the velocity is more than that, so this is 1.5 actually here, this is 1.5. If anything more than that, this area is, they have found out that there is abnormal flow and that there's a high chance of fetal height drops. So you don't have to know all this jargon, but you have to understand that there are two methods of detecting fetal anemia in current practice. One thing is the invasive method where we take amniocentesis and take amniotic fluid, and we check the bilirubin level at 450 optical density. The other method is we check the peak systolic velocity and anything above 1.5 multiples of median. Now you don't have to remember this because 1.5 multiples of median කියන එක මෙන්න මේ වගේ graph එකකින් අපිට හම්බ වෙනවා. You just have to check what is the peak systolic velocity. We know what is the 1.5 multiples of median value. This is the value at each week. This is the week. My cursor is showing the week now. For each week, the 1.5 is here. Anything above this, we are in trouble. Anything below this, we are okay, right? That's what you have to understand. So what will happen if the baby has gone beyond the cutoff values, or that means in the zone 3 in the Lily's chart, or in more than 1.5 multiples of median? What can we do? We can do a thing called, now we have to see for sure actually what is the hemoglobin level of the baby. For that, we can do fetal cord blood sampling. Right? Now, this is not easy as told. So what you do is you put a small needle through the mother's tummy, and you go into the umbilical cord and catch the umbilical vein and give a small injection. You call it pancuronium, and you anesthetize the baby, and the baby won't move after that. And you slowly take some blood of that and send for investigations, right? So, and once you do that, you check the anemia level and you see how much you have to correct. So say the baby is severe anemic, we might have to give some blood. So there are few methods of giving blood. One thing is, now that we have gone into the cord, we can give the bloods directly into the baby's cord, and that will be intrauterine transfusion, right? So we can give intrauterine blood transfusion to the baby through percutaneous umbilical cord blood sampling. But the other method is we can do intraperitoneal transfusion as well. That is, we just give the blood into the peritoneal cavity of the baby, and the baby's peritoneal cavity acts as a membrane, and it will suck out the blood cells, but it's not as effective as cordocentesis, so giving blood directly to the cord. So when you are giving blood, there are 4 things that you have to fulfill on the blood that you are giving to the baby. It should be O negative. It should be CMV infection negative. It should be washed and irradiated packed cells. It is not whole blood, it is packed cells, because we don't want to give more fluid, the baby will get heart failure. And it must be cross-matched against the maternal blood, because we don't want more sensitizing events in the mother when we are trying to give blood to the baby. So the problem of intrauterine anemia can be averted by these 2 methods. That is only if we can't deliver this child. If we can deliver, if this anemia is evident at 34 weeks, what I would do is I will deliver the baby soon as possible and then give it to the pediatricians, and they will do neonatal blood transfusions and revive the baby. But say the baby is only 20 weeks or 24 weeks, we can't deliver the baby still. Then we have to maintain the baby inside the uterus. For that, this severe anemia is causing trouble and heart failure. So for that, we might have to give transfusions, and that will be done by using chorecentesis or intraperitoneal transfusion. So what are we going to do? The management of Rh negative isoimmunized woman in pregnancy. So when the woman is isoimmunized, we check the maternal unexpected antibody titers every fortnightly after 16 weeks. So we know that this woman is sensitized. So we're going to check the antibody titers fortnightly, every other week. That is once in every 2 weeks we check the antibody titers after 16 weeks. And when it comes to critical titer, the critical titer is given as I told you, 1 in 16, 1 in 24, 1 in 32, 1 in 64, and like that. When it comes to a critical titer, we do our tests to check the fetal anemia. That we have 2 tests, as I told you. Either we can do a middle cerebral peak systolic velocity, or we can do amniotic fluid spectrometry. And if that has come to a critical titer, and then we have to decide whether we can deliver this child. And if we can deliver, we'll deliver the child. If we can't deliver this child, we have to do intrauterine transfusion to the baby. If the gestation is mature enough, more than 35 weeks, we have to deliver this baby as soon as possible. Then we can achieve a successful outcome. Okay. I think I tried to make myself clear as much as possible. Can you hear me now? Yes. So, in a nutshell, I will summarize this lecture. I will give this lecture forwarded to the department. In a nutshell, when I summarize, we normally try to prevent Rh isoimmunization. That is done by giving antenatal and postnatal Rh prophylaxis. Now, antenatal prophylaxis, we can give 1,500 at 28 weeks or 500 units at 28 and 34 weeks. And postnatally, we give 1,500 within 72 hours of birth. That is what we have to do initially. Failing to do that, then the mother has the chance of getting sensitized. Once the baby is sensitized, the mother is sensitized, then you can't take it out. Mother is sensitized, and that is a lifelong event. Then it is about us to how to manage a woman who's sensitized. If she's sensitized, what we are going to do, we are going to check the mother's antibody levels by checking a thing called unexpected antibodies. That we do every fortnight after 16 weeks. If the mother is Rh, if the mother's the antibody titer becomes critical, which the lab will tell us now it is critical, then we will have to check the baby, because the baby now can be affected. I mean, provided the baby is positive. So we have to be pretty sure the baby is positive first, that we know if the father is positive. If the father is negative, mother should be negative. If the father is positive, then the baby is very high chance that the baby is positive, right? So if the baby is positive and the mother's treat is critical, we have to check the baby now. To check the baby, there are 2 methods. One thing is the amniotic fluid spectrometry. Other one is the middle cerebral artery Doppler. Either way, both are there to detect fetal anemia. Once there's fetal anemia, if we think that the critical level is reached, now we have to see actually how bad the anemia is and how much blood we have to give, or can we deliver the child. These are the options left. For that, we do a thing called PUBS, percutaneous blood sampling. For that, we put a small needle, go to the umbilical vein, inject an anesthetic drug to the baby. Baby will be stopping moving. Then we take some blood, quickly check the blood hemoglobin level, calculate how much blood we have to give, and we transfuse to the baby. If we can't do all this stuff and we think the baby is anemic with the tests, we are not going to check the hemoglobin level or anything like that. We can just put a needle inside the baby's tummy and give intraperitoneal transfusion even. That's a crude method. But the ideal method is what I told earlier. Once you do that, you can maintain the baby as much as possible. that you have to give irradiated Rh negative equal to mother's this thing and packed cells. And those are the requirements when you're transfusing blood to the baby. Once the baby's survival is achieved outside, any gestation that the survival can be achieved outside, it is better to deliver the baby rather than managing the baby intratracheal. So that is the take-home message. Okay, everybody got it?
Excuse me, sir.
Yes.
I have a question, sir.
Yes.
Are there any adverse effects to the mother of giving 1,500 international units instead of the recommended 500 international units of Rh iso immunization?
No effect to the mother whatsoever. It just destroys in the system.
So why is it 500? Why is it that 500 international units is recommended?
That is more than adequate. For 90% of fetal blood mixing is less than that 10 ml. So, I mean, we are overdoing it. That's why. I mean, this antibody production. I mean, you have to get this Rh negative antibody. The ROGAM has to be made. No, it is not freely available. It's very expensive. One vial will cost about 8,000. Right?
Yes.
So, I mean, why do you want to give overdose? I mean, it will not serve any purpose. No, that's why. Only thing is, these vials have come in 500, 1,500 and 1,000 unit vials. In Sri Lanka, we have only 1,500 vials. The thing is the price difference is not that much because the Indian one or something was only we use the thing called ROGAM. There's another one called ROClone. So different vials are there, but still we have the only 1,500 unit vials. That's why the problem. But it is not going to do any harm to the mother. Don't worry about it.
Thank you.
Okay then. I'll send this lecture to the department. Right?
Okay, sir. Thank you, sir.
Okay.